update session 2. So the first speaker is Min Lu. Okay. Oh, is there Min Lu? Not here. Okay, so the next presenter is Zhao Fei Wang. Okay, so so the next speaker, Zhao Fei Li. No one is here.
I think author number 11 is there.
Yeah.
Yeah, you
Am I the only one here?
uh,
So you want me to start?
any other authors in the audience? So you are the only one. Yeah.
Okay. Well, I've got plenty of time to present myself.
The stage is all yours. Anyone, only one. Yeah.
Which side should I go?
Number 11 author कौन से side पे?
Good morning. I'm
Zakynthos.
Xiaofei Wang from.
Number 11. Zakynthos.
Can I have a pointer? Laser pointer? Thank you so much. I have so much time, I'm going to take a picture with you guys. Okay, so I'm Jack Santo Domingo. I work for as clinical affairs manager and senior research scientist for many companies, a contact lens company in Japan. I am also involved with the British Contact Lens Association as a global ambassador and task force member for the International Myopia Institute. And today I'm going to be speaking about some results that we have about 11 years of orthokeratology contact lens wear for slowing myopia progression in children. Here we go. And these are my disclosures. I have already mentioned I work for Menicon. Okay, so the efficacy of orthokeratology in slowing myopia progression in children is very well established with systematic reviews and meta-analysis reporting reductions in the axial elongation of the eye of around 0.28 millimeters over a 2-year period in comparison to control groups of single vision spectacle lens wearers. However, most of the evidence is limited to studies in which lenses were worn up to 2 years only. Therefore, the purpose of this study is to compare the axial length growth between a group of orthokeratology contact lens wearers and a control group of distant single vision lens wearers over an 11-year period. So in terms of methods, we recruit white European subjects 6 to 12 years of age with myopia up to -4 and astigmatism equal or less than 1 diopter. We prospectively allocate subjects to either orthokeratology or distant single vision spectacles for 2 years. And during these initial 2 years, we measure axial length every 6 months. This was initially a 2-year clinical trial, and at the end of 2 years, the trial was completed. But then sometime later, we decided to call the subjects into the clinic again, so invite them for a free eye test. And that was done 5 and 7 years later, so 7 and 11 years since baseline. And during these 2 additional visits, we measure axial length again and analyze changes in axial length using 2 statistical approaches. A more simple one consisting on comparing changes in axial length between groups at each of the different time points using an impaired t-test, and a more complex statistical analysis consisting on an intent to treat approach using linear mixed models. In the second approach, in the linear mixed models, we assess the potential effect into the axial elongation of a number of baseline demographic variables that were included into the model as covariables. So this is the flow chart of subjects follow-up in the study. So we initially assessed 69 children, 61 were enrolled in the study, 31 in the orthokeratology and 30 in the control. 29 orthokeratology and 24 controls completed a 2-year visit. 14 orthokeratology and 16 controls came to the 7-year visit, and 10 orthokeratology and 16 controls attended the 11-year visit. However, only 10 orthokeratology and 10 controls completed all study visits. So these are the baseline demographics for the study. I know it's a very busy slide, but basically what I want to highlight here is that both study groups, the orthokeratology and the control, they were very well matched at baseline. No significant differences in baseline demographics between these two groups. But we also look at differences between retained and dropout subjects for both the orthokeratology and the control groups. So in the control, no differences here at all, but some differences between retained and control in the orthokeratology, a slightly older age in the retained versus the control, and a slightly different also male-female ratio. So these are the key findings of the study. We have changes in axial length in the y-axis over time, in the x-axis for the orthokeratology group in green, and the control group in red. With the more simple statistical approach, the imperative test, we found significant differences between groups at the 1, 1.5, and 2-year time points. So less axial elongation in the orthokeratology group compared to the control group at these time points, and it almost reached statistically significant at these 2 time points. When we analyze the data in a different way, using the linear mixed models, what we find the significant differences here at the 7 and 11-year time points. Here you can see the treatment effect. So the difference in axial elongation between the orthokeratology and the control groups. As you can see here, the treatment effect increased over time. The effect continued to accrue over time, and the absolute treatment effect at 11 years, so the difference in axial elongation between the orthokeratology and the control group at the 11-year time point is 0.69 millimeters. That's probably around 2 diopters of myopia control. We assess the potential effect on the axial elongation of the eye of a number of baseline covariables, and there is one that is worthy discussing that I think is pretty interesting, which is central corneal power, which is plotted here against the 11 years change in axial length. And as you can see here, subjects with more corneal power, so steeper corneas, so less axial elongation compared to those with flatter corneas or less corneal power. So in summary, conclusions, this study is the longest reported period of orthokeratology lens wearing slowing axial length. We found a 11-year treatment effect of 0.69 millimeters over an 11-year period. Typically, not just with orthokeratology, but with myopia control treatments, there appears to be an initial burst in efficacy, but this study demonstrates that the myopia control effect continued to accrue over time. The myopia control effect is independent of most baseline demographic variables, but it's dependent on corneal shape. So patients with steeper corneas are likely to benefit more from orthokeratology for slowing myopia progression. And of course, like any study spanning for over a decade, it suffered from a number of limitations, but these results inform eye care practitioners as to what sort of myopia control efficacy can be expected with long-term orthokeratology lens wear. And with that, thank you all very much for your attention.
Thank you. Very nice presentation. So is there any comments or questions from the audience?
What were the reasons for the dropouts?
Well, in dropouts in the control group, they typically drop out because they go and they look for myopia control somewhere else. So
What about the patients who are not in the control group?
from the orthokeratology group, we have very few dropouts, to be honest, but they are primarily related to comfort issues or compliance issues or loss to follow up. Sometimes we don't know.
Any side effects or complications, particularly corneal in relationship to the lens?
Not really, no. Of course, you sometimes get some central corneal staining, but that has very much to do with the way they remove the lenses on. I know there has been a lot of debate about whether orthokeratology lenses are safe or no, but the rate of complications is very low, and the rate of MK, now there is a number of good studies showing complication rates of microbial keratitis not so different from soft contact lenses.
And all these cases were axial myopia?
Yeah, they all have. Yeah. So they all had around 2 to 2.5 diopters of myopia at baseline.
But the myopia was primary axial myopia.
Yes.
Not due to other factors.
Yeah, well, I think 70-80% of all myopias are axial myopиas.
Yeah, but are the lenses applicable for secondary induced myopias, not primary myopias?
Sorry?
Are these lenses applicable and useful even secondary myopia? Apart from axial myopia.
Yeah, that's a good question. I don't know. I don't really know. For axial myopias, for sure. I
With the
think
lenses, I will respond to that. The lenses are good for, because they're placed on the cornea, so they will be good for corneal myopia, like curvature myopia. Axial myopia, of course, but not
Yeah.
for lenticular myopia, of course, because the lenticular myopia is at the level of lens, so it will be difficult to treat lenticular myopias with ortho-K lenses.
Since you talked about steeper corneas,
Yeah, I had a question on that. You can ask and then I will ask. No, I think the steeper corneas have better response, mainly because, with ortho-K you can flatten them much
That's
more
right.
easier. If you have a flatter cornea, it would be difficult to flatten it more. I just had a quick question whether there was a washout period when you measured axial length, like you weaned off, because the ortho-K, when you typically give them ortho-K lenses, the effect of ortho-K would remain even if they don't wear it for almost a week. There will be an uneven refraction, but it will last for almost a week. So when you were measuring axial lengths, did you do a washout period, like you told them not to wear for 15 days and then measured axial length? Because steeper corneas typically will be flatter, and there's a possibility that it may intervene with axial length measurements.
Yeah,
And
no.
another quick question, I'm sorry. The methods of measuring axial length, did it change over such a long follow-up?
No. So one by one. We didn't do any washout period. The amount of epithelial thinning that you get with orthokeratology lenses is about 3 microns, and that's below the resolution of the IOL master that we use. So even if we do washout, the axial length device is not accurate enough to go to that level of precision. So that's why we didn't do a washout. The other question was about the second one. The steeper corneas. Yeah. So orthokeratology lenses, even for refractive correction, not for slowing myopia progression, they work a little bit better on steeper corneas than flatter corneas. We know that. But all subjects of the study achieved really good refractive correction. So they were all good, well corrected. But despite this, those with steeper corneas saw more myopia control effect. And we think that's because by being able to push the cornea more and remove more epithelial tissue towards the periphery, we get a better we got a greater increase in spherical aberration and a more myopic periphery, and we think that's probably the reason why we're getting a better myopia control effect. Yeah.
To flatten out 3 or 4 diopters of myopia, probably be in the tune of 40 to 50 microns. So still my question is, to contradict your point, would it still affect the axial length change?
Yeah.
If we correct one diopter, it
Yeah.
is approximately 10 to 12 microns flattening in the corneal level. So if we correct 3 to 4 diopters, it is in the tune of 50 microns maybe. But my question still remains, would it still affect the axial length change? Is it statistically significant?
Right. Well, the subjects in this study, they have 2 to 2.5 diopters of myopia at baseline. We didn't have any, I think, 3 to 4. But anyway, all the literature that I have reviewed is the amount of corneal thinning that you get with orthokeratology is not able to be measured with an optical biometer. It's not, the resolution is not that good for that particular purpose.
Another question, what we face in India to convince...
let me one more point to that one. Yeah. And also the method that we used for measuring, it was all the same. So baseline and throughout all the study visits, the axial length measurements were taken right after when they removed the lenses. So we just systematically use the same method.
Okay, but it takes about 14 days time to to be at the normal level of precision of the lens.
Yeah. Sometimes even longer for long-term orthokeratology is even sometimes longer.
Yes. So my another question, if time allows, sir.
Are there any other speakers in the audience? Are there any other speakers out of the 12 presentations? Are there any other speakers?
I think hall managers, sir, can give them a call to.
हाँ, उनको phone कर दीजिए ना, अगर number है तो. I think all of them are international speakers. So we just have one speaker, and so he's all yours. You can grill him.
So just for.
I think you might as well take a chair.
Okay.
Take time.
Sir, I just wanted to know, in your practice area, how difficult is it to convince a patient or parents to go for orthokeratology? Because in India, the challenge that we face, even though we know orthokeratology is effective, to get them to understand and to get convinced about is the toughest challenge that we face. And another question is, what is your take on orthokeratology combining with atropine?
Right.
Are you doing anything to address that point?
Right. So I think this study was started in 2005, and at that time, the only treatment that we have for myopia control was orthokeratology. So it was very easy to convince parents for enrolling children on the trial. I think now, with so many different treatment options, we have like spectacles, we have soft contact lenses, we have orthokeratology, we have atropine, we have red light therapy. Now is more difficult to convince parents for one particular method or on another because they have so much possibilities. It is also extremely difficult now to run any clinical trial and be able to have a control group, because now we are aware of the problem with myopia, and even if typically a parent will enroll in a study, but as soon as they find out that their children has been allocated to the control group, they will just leave the trial. So I think there is a trend now towards going for non-inferiority trials, where you just allocate children to a control group, which also receive another myopia control treatment that you use as a control. With regards to the combination of orthokeratology and atropine, I think there is a lot of evidence now that these two, there is a synergetic effect by combining the two treatments. I think there is also some really good evidence now showing that 0.01% atropine is probably not effective for myopia control. It might, and certainly it has no impact on reducing the axial elongation of the eye, and there is a trend now to go into higher concentrations like 0.05. And I think also there is a trend now for starting myopia control treatment even in not fast progressors with combo treatments. So start from the beginning with something like spectacles or contact lenses and atropine, or optical and red light therapy. So I think we're going to see a lot more of that in the next few years to come.
If I could have an opinion from Jethani sir as well,
Yeah,
especially for higher age group and with higher degree of myopia.
Regarding high degree of myopia,
I mean,
you
with
should
combining
I think,
orthokeratology with atropine.
why not? I mean, definitely. I won't agree that atropine is not working. It is at least working in Indian population. I think the papers which are the most of the papers are from US, especially Dr. Michael Rapka's paper that atropine is not working in their population. But there are multiple papers which have conclusively proven that atropine is a good alternative. Combining it with ortho-K is a wonderful thing if patient agrees, and if the cost permits, why not? Your comments?
Okay, so I'm not familiar with this kind of myopia prevention. So, but in Japan, I'm from Japan. So in Japan, also keratology is also familiar. But normally, most of the patients want to use the eye drop like atropine and so on. So from recent days, just one pharmaceutical company starts the eye drops officially. So in the future, we will get good information from those kind of products.
And with the advent of soft ortho-K lens also, I think the trend would be even more popular combining with atropine, I guess.
Yes, totally agree with you. So combining the both or three, like atropine and also keratology, and also like light therapy, those is, I think, this is very good thing for the myopic prevention. But there are some like complications and so on. So we should take care about it.
Thank you so much.
I think, is this working? Yeah. Takahiro Hiraoka from Tsukuba University, he has published some really good studies showing the effectiveness of orthokeratology lenses in Japanese children. So in Japanese children, it works also pretty well. Yeah.
So also, I think that also keratology is very nice product, but in our outpatient clinic, there is a big problem, like the also keratology for children. So they can't use correctly, like changing the right and left also keratology and so on, and also like the other complication of using the contact lenses. So yes, that is a big problem. But also keratology efficacy, I think that is very nice.
Well, I don't agree fully with what you say, and I think orthokeratology offers a very unique type of correction to children in a very controlled environment. So the lenses are used only at home, just before going to bed. The parents are there. The lenses are removed in the morning. Children go to school. They don't have to wear glasses. They don't have to wear contact lenses. They don't have to wear anything. They have the refractive correction, and they also have myopia control benefits. Right? When children, I think what we have also seen with any myopia control intervention is that compliance play a key role in efficacy. So sometimes we don't see very good efficacy with the spectacles because the children remove the lenses, and they go out after the school, they want to play. Orthokeratology offers a very unique opportunity for these children. And you were asking me for how do you convince parents. I think the key thing, and orthokeratology is more expensive, and that's a sensitive issue in India. But by not wearing anything during the day, I think that's a compelling argument for convincing parents to go into this particular treatment.
So I would just put up one last comment that you know, if orthokeratology has been there since almost 2.5, 3 decades.
Yeah.
Yeah, and there was no myopia control treatment even
Yeah.
then. Atropine has just started 8 to 10 years back, and still
Yeah.
you have more patients on atropine.
Yeah.
So there has to be something which we are missing out in orthokeratology, which we are not able to, not in terms of efficacy, but in terms of compliance or in terms of something, because it has not picked up. We have to
Right.
agree and accept to that, and we can agree to disagree. But the point is that orthokeratology is a wonderful treatment. There are wonderful things available with orthokeratology. But with atropine, probably because of the cost, at least in India at this
Yeah.
point of time, atropine is the,
Number one. Yeah.
yeah, it is, because you know, even in absence of atropine, orthokeratology did not pick up much. Maybe it
Yeah.
was the cost, maybe it was the compliance. So we will, you have any comments?
Yes, I agree with you. So the problem is cost and the safety. So I think the most of the problem is resolved by their parents. So these are the studies about the children, of course, yes, but most of the problems in the actual daily life is the parents, because the children cannot use correctly.
Right.
And also the parents have to pay the money.
The endpoint, when you say now, it doesn't need to wear the lenses. Now arrested to progression.
So basically, see, with ortho-K, the point is that, you know, you are glass-free. So some of the patients do continue even after 18 years of age. If they don't want to go undergo LASIK or surgery, they do continue. So there is no, I mean, then you stop myopia progression, but then you are using it in lieu of refractive surgery. So endpoint normally is non-progression beyond 0.5 diopter per year, but then you have to, once you know, it is like this, that once you start wearing ortho-K lenses, you are glass-free during the day hours. And so it is more like this, that you become habituated because you have started at a very young age.
What is the cost of the lenses here and what is the life of a lens?
So typically it is 2 to 3 years if used correctly. Cost in India to the patient is around 60 to 80,000 depending on the manufacturer.
Per lens.
Pair.
It can be cheaper also.
It can be, no, I said to the patient, because that is the MRP on the lens. To the doctor, it all depends on how many you have, it is a market thing, but MRP is around 60 to 80. But to the doctor, you can get it around 25 to 45, depending on which company it is.
It is more popular now for the refractive pool. LASIK rejects actually now.
Yes.
For orthokeratology rather than the therapeutic pool we should look at.
Patients in whom you cannot do laser surgery. Yeah, we have a video from the second author, and we can play it. Yeah.
Good morning. I'm Xiaofei Wang from Beihang University. Today I will present our work on factors influencing gaze-induced optic nerve head deformations in high myopia. Glaucoma is the leading cause of blindness worldwide. It is characterized by optic nerve neuropathy and visual field loss. Its pathogenesis remains unclear, hindering prevention and treatment. High myopia is a major risk factor for open-angle glaucoma, increasing risk more than sevenfold compared to ametropic eyes, and will affect an estimated 10% of the global population by 2050. The optic nerve head, or ONH, is the primary site of glaucoma damage in glaucoma. So understanding biomechanical deformations here is critical to explain disease progressions. Traditional IOP is considered to be the main driving force that can induce optic nerve head deformations. But we all know that in Asia, many open-angle glaucoma subjects have normal IOP levels. So there might be other factors that influencing optic nerve head deformations. Actually, many biomechanical factors, including IOP, cerebrospinal fluid pressure, or CSFP, ciliary muscle tension, and optic nerve traction during eye movement, they all induce optic nerve head deformations. In our previous work, we have demonstrated that the optic nerve traction during eye movement can induce large optic nerve head deformations. Using parametric finite element modeling, we also demonstrated that several key morphological factors determine the magnitude of eye movement-induced ONH strength. Specifically, we found that the optic nerve tortuosity has a large impact on the strain magnitude. However, in high myopic eyes, the optic nerve becomes more curved as axial length increases. The increased optic nerve tortuosity in high myopic eyes may protective against eye movement-induced optic nerve head deformations. So our research gaps. First, it's unclear if gaze-induced optic nerve head deformations scale with axial length, and the rule of scleral stiffness and shifted eye movement center remains unquantified. The aim of this study is to use in vivo OCT imaging and finite element modeling to explore ONH deformations in high myopic eyes during eye movement. We built two whole eye finite element models, an ametropic eye and a high myopic eye, each including detailed optic nerve head structures. The high myopic model has a longer axial length, a thinner scleral thickness, and a thinner corridor thickness. We also applied baseline IOP and baseline CSFP on the model. Then 13 degrees of adduction and abduction were also applied. We collected OCT images of high myopic subjects and non-high myopic subjects at baseline 20 degrees of adduction and 20 degrees of abduction. We enhanced our OCT images using adaptive compensation algorithm and segmented each tissues in the optic nerve head. We then used a 3D strain mapping pipeline to measure tissue deformation in vivo during the horizontal gaze. Here you see 3D visualizations of ONH deformations in adduction and abduction. Finite element model predictions show significantly large ONH strengths in high myopia, and strengths were greater in adduction than abduction in both groups. In the high myopic model, reducing scleral stiffness decreased lamina cribrosa effective strain during gaze, whereas in the ametropic model, it increased the strain. In high myopic eyes, the elongation of the eyeball shifted the geometric center posteriorly more than the eye movement center. So this results in a relative anterior shift of the eye movement center. This relative shift amplified the LC effective strain during horizontal eye movement, particularly during adduction in high myopic model. In vivo OCT measurement confirmed that LC strength increased with axial length for both abduction and adduction. This plot shows a clear positive correlation between axial length and measured LC strain in adduction and abduction. In conclusion, our study using finite element modeling and in vivo OCT imaging show that ONH deformations in adduction were on average higher than those in abduction, both in high myopic and in ametropic eyes. And as axial length increases, the LC strength increased both in adduction and abduction. Scleral stiffness and the position of eye movement center significantly modulated LC strength. These findings may provide new insights into the biomechanical factors that may contribute to the higher risk of optic neuropathies in high myopia eyes. Thank you for your attention.
Are there any other authors who are present? Yeah, I think I just wanted to comment on the second paper. What he's trying to show is that if there is a more strain when you move in high myopia, when you're trying to adduct the eye, you're putting a higher strain on the optic nerve, and that probably is one of the reasons why you have a temporal crescent, because the optic nerve head, there is a gaze induced this thing. Another possibility, we can also in future, maybe they can do some work on the fact that our eyeballs normally should be sitting in exotropic position because of the orbits, but they are sitting right straight, so they are already medial rectus is already under strain, and so if we compare with the animal models, our eyes are already in slight esotropia. It is actually orthophoria for humans, but the medial rectus has a stronger tone on the eyeball, and that probably maybe one of the reasons why we normally have the optic nerve shifted nasally, and there is a temporal crescent. That is what I understood from the paper, and you can also comment.
Okay, so I have comments to this presentation. So as for myopic complications, glaucoma is a very big problem. So glaucoma related to high myopia is not resolved yet. So like for other complications like myopic traction maculopathy and so on, we can do surgery. So this problem is very hard, and we should get to the point. And so this study is very nice, but we should take care about the lamina cliplosa defect, and also like gamma zone and so on, progressive of gamma zone. So if this study goes to the like real patient studies, that is a very big achievement, I think.
If there are not, are there any other authors? If there are not any other authors, I think we can close the session. Sure.
Okay, thank you so much.
Thank you, everybody.